Hello, good morning, everyone. Uh,
Chat.
this is my,
No me lo pongo aquí.
it is a pleasure to me to share this knowledge that we have accumulated from the last
Ya sé.
30 years about Hirschsprung disease.
No,
Um, I am honored to work now in
¿para qué?
this beautiful hospital, Children's Hospital, Colorado, and be part of this amazing group in the International Center for Colorectal and Urogenital Care.
¿Y aquí cómo le hago?
So this morning, I'm going to show you some slides to explain about Hirschsprung disease, what everybody should know.
¿Regreso?
Hirschsprung was described many years ago, and today
Enviar, enviar.
is unbelievable
¿Ah?
that many
Sara,
basic
Luis, quién
concepts
sé qué
are
putas.
missing in the diagnosis
Luisa,
and
Seferio.
during the treatment of this patient. And the most important, the follow-up of this problem. First of all, you can see here in this slide what is a normal large bowel that we call the colon. And you need to recognize on the left side of your screen, the left transverse, the right transverse, left or descending colon, and then you can see the sigmoid and the rectum. The sigmoid and the rectum are the natural reservoirs for stool. You can see the difference. This area of the colon has these transverse lines that we call Haustra. That means worked in different speeds, different frequency of contractions. And the lower part is the rectum and the sigmoid that work slowly because we need to have these areas to hold and accumulate the stool and then to have a bowel movement. All the patients with Hirschsprung, 100% of the patients with
No,
Hirschsprung suffer from this area. In other words, the area that is always affected in patients with Hirschsprung is the rectum and the sigmoid. In consequence, as you will see in the surgical treatment, they will lose these segments of bowel, which is going to be very important for fecal control and during the follow-up. So Hirschsprung disease is a problem that affects always the rectum and the sigmoid. What happened in Hirschsprung disease? Hirschsprung disease has a functional obstruction. It's not a mechanical obstruction. What is the difference? The difference is that mechanical obstruction, you can see the rectum here, and there is no communication, okay? So if you introduce here a catheter, you cannot reach this area of the colon. In a functional obstruction, like Hirschsprung, you can see here the dilated segment and then the segment with Hirschsprung, but they are connected. They have patency. They have lumen together. So you can introduce a catheter here, and then the catheter is going to reach the normal bowel. Even when it's dilated, we say it is normal because this segment possesses ganglion cells. So when you have a baby like this one in the middle of the screen with abdominal distension, the history of vomiting, he's not passing stools, you need to think about the patient probably has Hirschsprung disease. This is very, very important. And avoid to do an emergency operation. This was in the old times. When we had a baby with abdominal distension, all the surgeons took these patients to the OR to do an operation to find what's happening inside the belly, inside the abdomen. Today, if we have a newborn with this clinical picture, we can try to relieve the obstruction, placing a catheter in the rectum to think about this patient has probably Hirschsprung. talking about Hirschsprung, there are three types of Hirschsprung that you need to understand and you need to know. One is the rectus sigmoid, the second is the long segment, and the third is the total colonic. The rectus sigmoid, as its name says, it affects the rectum and the sigmoid.
¿Qué
The
dice?
long segment affects the rectum, the sigmoid, and the left colon. And the total
Sigmoide.
colonic affects the rectum, the sigmoid, the left, the transverse, and the right colon. And the dilated segment is going to be in the small bowel that we call the ileum. These three different types of Hirschsprung require a different operation. These three types of
¿Ese
Hirschsprung
qué puso?
have different
¿Qué dice?
prognosis. The most common problems that we have seen
Reunión y checa
is
aquí
in the
la fecha.
long segment because surgeons try to do the pull-through, which is the treatment, with a segment that is very difficult to move into the pelvis. So this is the most challenging, I want to say,
Por favor,
surgical
señor familiares, apague.
treatment. And total colonic also is a common error to treat in many groups because total colonic requires the resection of the entire colon. If you do this operation in early age, like weeks, months, or in the first year of life, the family, the parents, and the patients are going to suffer a lot because the patient is going to have multiple bowel movements and is going to stay peeing, and they are going to have a severe diaper rash. In our center, we have a strict protocol to provide the best quality of life in patients with total colonic ganglionosis. As you can see now, the most frequent type of Hirschsprung is this rectosigmoid. But even though you can see in the gray line, even whatever is the type of Hirschsprung, always the rectum is the organ that is going to provide the diagnosis because the diagnosis is based on a rectal biopsy, as we will see. How the parents, the family, can suspect that the patient has Hirschsprung disease? Well, because this is a congenital problem. Congenital problem means the patient born with the problem. It's not the patient that has constipation when he is 1 year or 2 years. When the patient has constipation and he has 3 years and he starts with problems, most probably this patient does not have Hirschsprung. This is a congenital problem, and usually this problem begins since newborn. The patient is not having bowel movement, he cannot pass meconium, is vomiting, the belly is distended. You need to do something to stimulate the rectum and the anus to provoke a bowel movement. All these clinical features may or should suspect Hirschsprung disease. This is an X-ray that could be from enterocolitis related with another problem, could be intestinal atresia, could be an imperforate anus, could be whatever. So the X-ray is very important just to confirm that the patient has obstruction. And we divide obstructions in low and high obstruction. So you need to know that the patients that have low obstruction, they have a lot of gas in the belly. The belly has all the bowel distended, usually the large bowel and the small bowel, right? So this is an X-ray that gives us the idea, and we need to suspect that this patient could have Hirschsprung disease. One thing that is very important, and I think is the most important in this conference for you, is to know about irrigations. Irrigation is completely different from enemas. We have seen in many countries, in many hospitals, that patients with Hirschsprung are prescribed with enemas, and the patient becomes really sick. Enemas are forbidden in patients with Hirschsprung. You don't have to give enemas in patients with Hirschsprung because if you give an enema, the liquid is going to be in this area, and this area is has obstruction, so the patient is going to be sick. What we need to learn, and we have to do in patients with Hirschsprung to resolve the obstruction, is irrigations. We have to do irrigations. Irrigations is very easy. You need to place a catheter, which is this red line, and the catheter is going to allow to move from this area gas and poop to the outside, and the patient is going to relieve this obstruction. This is a video that is going to demonstrate in this animation how an irrigation work. So this is a catheter, could be a Foley catheter number 20 French. This orifice allowed to move out the gas and the stool, and then you can remove out a little more the catheter, and then you need to flush with saline, 20 cc's of saline several times until you obtain clear return. This you can spend 15 minutes, 20 minutes, whatever it is, to relieve this one. This is the medical treatment for Hirschsprung. Also, irrigations are the medical treatment in patients with post-operative obstructions, as we will see. So irrigation is the most important treatment that the families, nurses, and doctors they need to learn, and they need to prescribe in patients with Hirschsprung. We have to take a rectal biopsy in all patients with Hirschsprung. The rectal biopsy is the gold standard procedure to confirm the diagnosis of Hirschsprung disease. The presence of these cells that you can see in this slide, we call these ganglion cells, which are neurons in the bowel. These ganglion cells should be present in all human beings. In the babies with Hirschsprung, these ganglion cells are absent. And so you can hear words like aganglionic, absence of ganglion cells, no ganglion cells present in the rectum. So it is very important that you remember that there are other studies to confirm or try to confirm Hirschsprung disease. Manometry, which is the rectal manometry, contrast enema, right? And the rectal biopsy. Today, after many years, the rectal biopsy is still the gold standard. So if you have a patient with a suspicion of Hirschsprung, and they say, oh yeah, could be a Hirschsprung disease because the contrast enema shows a transitional zone, the patient needs a rectal biopsy. The manometry, the rectal manometry, and the contrast enema, they offers false positive and false negative results. So the rectal biopsy is still the gold standard to confirm the diagnosis of Hirschsprung. The contrast enema is a radiological study that we perform in patients with Hirschsprung, and we inject from the rectum a contrast, which is not barium, is not a barium enema. We use hydrosoluble dye contrast. So we inject from below, from the rectum, and the idea is to find this area, the area where the colon is dilated. And is dilated because the distal segment has obstruction. So this obstruction produces this dilation. That's why you can hear in some websites Hirschsprung like the congenital megacolon, right? But the megacolon is the consequence of the problems. The megacolon is the area with ganglion cells. So this colon possesses ganglion cells. So the idea of the contrast enema is to inject this liquid that we can see in the X-ray in color white or white color, and then you can see this dilation. This is the transitional zone, is the transition between the aganglionic segment and the segment with ganglion cells. To do this contrast enema requires a perfect protocol. It's a complete different study uh, that you can hear for other problems like polyps, malrotation, intussusception, cancer, whatever. So the radiologist, when you order a contrast enema, your doctor, your surgeon, your GI prescribe a contrast enema for Hirschsprung disease, this study should be performed under a very strict protocol. It's not just the contrast enema that we usually use for all other problems. For Hirschsprung, require a specific protocol. The surgical treatment of Hirschsprung, you can imagine now how can we repair this problem. After the medical treatment, which is irrigation, what we have to do is to remove, to resect the segment that does not possess ganglion cells. In other words, we have to remove all the length of bowel without ganglion cells. The rectosigmoid and the left colon and some segment of the transverse colon if it is a long segment, or we have to do a total colectomy. We have to remove the entire colon if the patient has this type of Hirschsprung. Then we have to move the proximal bowel with ganglion cells and then to connect in the pelvis, in the rectum. We call this the pull-through. And there are different types of pull-through. The technique described by Swenson, Suave, Duhamel. Any of these work perfect, just is preference of the surgeons. This operation can be done with colostomy or without colostomy. Also, this is the preference of the surgeon. Currently, in patients with a short segment or rectosigmoid, we do this operation without colostomy, and we call this primary pull-through. And a primary pull-through requires and demands to have a complete group of providers with experience in radiology, in pathology, which is extremely important, is mandatory because we need to confirm the presence of ganglion cells during an operation. So the primary pull-through is really important today, but requires to work in a place with a good human infrastructure. And at the end, the third step is to create a good connection that we call the anastomosis from the colon with ganglion cells to the rectum. Below the rectum, very close to the anus, we have a little segment that we call the anal canal. One of the problems that we have seen in the last years is that many surgeons connect the colon with ganglion cells to the anal canal. If that happens, the anal canal is suffering damage, and we missing this area. And this area is very important to preserve fecal control. In other words, if the anastomosis is performed very low, close to the anal canal or over the anal canal, most of these patients or all of these patients are going to suffer fecal incontinence. So we are scared. We are really worried about this situation because it's not uncommon. This is an animation how to do the pull-through. This is the resection of the bowel without ganglion cells, and then the anastomosis. And this area is the anal canal. This is a beautiful operation, perfect operation. Even after perfect operation, 30% of the patients will develop a problem that we call colitis. Colitis, we don't know exactly why these patients present this problem. So it is important to let the parents know that after a good operation, perfect operation for Hirschsprung, these patients will suffer colitis. And colitis, as you can see in the x-ray, is an obstruction. This patient had perfect operation. The surgeon did a great job. Now, the stool and the gas is accumulated here and here, and the patient is distended, as you can see here. Looks like another patient with Hirschsprung, right? This patient usually does not require another operation. You need to be patient and you need to learn how to do irrigations. And today, the best treatment for this patient is irrigations. So, as I told you, irrigations is the medical treatment for patients before the pull-through and now after the pull-through. So doctors that do patient with Hirschsprung, nurses, and the parents should be experts doing irrigations. This is the most important medical treatment before and after the pull-through. And you can save the life of the patients using this procedure. In the past, many patients die because they had colitis, and nobody knows how to treat this problem. Today, the mortality after the pull-through should be zero due to colitis, because the irrigations save the lives of the patients and treat this condition. Thank you very much. If you have any questions, you can send in the chat, or you can write to our email or social media. Thank you very much, Andrea, for this opportunity.